I'm delighted to present my new work on systemic resilience and care work. But before I start my presentation, I would like to say that this work is actually very much inspired by Brigitte Anderson and Martin Rue at the Migration Research Hub. They had actually invited me to write a think piece on this topic last fall, and this has given me an opportunity to really think and learn more about systemic resilience and care work in the context of migration, and in my case, in Asia Pacific. So I really would like to thank both Brigitte and Martin for getting me working on this topic. I also want to thank my colleague, Sonia Michel, in the US, for her inputs and comments on the earlier version of my work on this. So, as we enter the year 2 of the COVID-19 pandemic, it has become, I think, almost a cliche to say that the pandemic has exposed the importance of care and care work and how our economies and social functionings depend on invisible work of care. Over the last year, we have seen a large number of older people, particularly those in long-term care homes, die as a result of the COVID-19 infections and or from the lack of care. We also have seen many frontline care workers catching and succumbing to COVID infections from their workplaces. We also as well, we have seen parents stressed out. Continue. Parents stressed out as they multitask their work and childcare at home. And of course, many unpaid family caregivers burning out from increased care burden due to the closure of or reduce community care services. Now, with the vaccine rollouts, and as we begin to contemplate the post-COVID future, policy conversations are beginning to focus on pathways to recovery and systemic resilience. Systemic resilience refers to the potential or the ability of social and economic systems to rebound after endogenous and or exogenous shocks. And of course, COVID-19 may be one of the most momentous shocks the world has shared in the last generation. A huge systemic shock can crack open social and economic fault lines, leading to disruptions and collapse of functions that cascades down social and economic chains, but it also creates opening for change. A resilient systemic response to our current pandemic, therefore, must capitalize on these openings to rebuild. Am I getting, okay. So in this presentation, I would like to discuss how we can build a resilient systemic response to the COVID-19 pandemic and future crises. I focus on systemic resilience in relation to care work and global migration of care workers from an Asia-Pacific context. Although I focus on Asia-Pacific, I think many of the issues and ideas that I will be talking about also relate to Europe, North America, and other parts of the world. Asia-Pacific is an important site to examine systemic resilience to global care migration because it is one of the major sites of global care migration, both as sender and receiver of migrant care workers. So in the rest of this presentation, I would like to first provide a quick overview of the pandemic's impact on care work and care migration, focusing on Asia Pacific. I then would like to discuss how we might achieve systemic resilience in global care migration. I would do this by first pointing out some of the problems or challenges of the existing global care systems. And then I would discuss how we might be able to build a more resilient system. So, what are the impacts of COVID-19 on care, care work, and care migration? There are now quite a lot of evidence confirming the unequal impacts of pandemic. Studies show that women, people of color, indigenous people, immigrants, and low-income families have been disproportionately and adversely affected. This is in part because they are more likely to work in occupations that require direct in-person contacts, such as care and domestic work, and therefore are more likely to be exposed to the coronavirus. At the same time, while the global demand for frontline care workers has increased, a large number of women in other low-wage service sector work, such as accommodations, food services, have been unemployed or furloughed because these are also the sectors that are among the first to be closed down due to COVID lockdowns. In the US, for example, the rates of age-adjusted COVID deaths amongst the indigenous, Black, and Latino peoples are more than twice that of white population. The situation is much the same in Canada and in the UK too. COVID-19 cases and death rates are significantly higher among Black and Asian population than white population. Migrant workers, and particularly the female migrant workers, are hugely affected by global pandemic, but their situations are much less known. This is partly because data on these people are both scarce and difficult to collect, and also partly because many migrants, particularly women, work in private homes or are confined in workplace dorms and therefore have restricted access to public spaces or to outside contacts. Now, I mentioned earlier that I focus my presentation on Asia Pacific. And again, this is because Asia Pacific is a very important region to study. It has the world's largest population and the largest number of older people. As you can see, Asia Pacific is a home to something like 60% of the world's population and more than 260 million older people. By the way, in Europe, the older people population is about 200 million, so it's pretty big too. Asia Pacific is also an important region to study because Asia Pacific and Europe are now the two largest migration hubs in the world. Asia Pacific is the world's largest supply of foreign healthcare and care workers and the largest recipients of care and domestic workers. So what are some of the pandemic's impacts on migrant care workers in Asia Pacific region? Our research found that COVID-19 had and continues to have tremendous personal, social, and economic impacts on migrant care workers. For many migrant care workers, the pandemic has further restricted what little mobility that was available to them. For example, one of our project research associates and one of the presenters for this conference, Shi Yang's work shows in China during the COVID-19 lockdown period, many migrant care workers were physically confined with the elderly people they care for. In Wuhan, many long-term care institutions closed their doors and locked the residents and direct care workers inside. Most of these care workers are, in fact, migrant women from rural regions of China. As Shi's work reveals, these workers had to make temporary sleeping arrangements in the staff room and eat food that was brought in through the barrier door. While many of these care workers were fearful of contracting the virus and stressed by the 24/7 total confinement, they nevertheless continued to care for their frail elderly care recipients out of a sense of commitment, obligation, and resignation. Elsewhere, COVID-19 has also worsened working conditions and compromised personal safety and mental health of migrant care workers. We hear about foreign domestic and care workers confined to the house to care for the sick or required to take on more work to comply with employer demands for more rigorous cleaning regimes, extra precautions in food preparations, and more personal care services, or who were laid out or faced pay cuts or given less food because of changes in their employer's fiscal situation. In Singapore, for example, the humanitarian organization for migration economics home, which is a Singapore-based NGO group, they reported a 25% increase in the number of distress calls from foreign domestic workers, reporting anything from overwork, verbal abuse, and inadequate rest within a month after the government imposed a circuit breaker lockdown in May of 2020. Similar reports, Similar reports of mobility restrictions, increased workload, and mental health concerns among foreign domestic helpers were also found in Hong Kong during its own circuit breaker periods last year as well. Reports from the Middle East, one of the largest destination regions for female migrant workers from the Asia Pacific, also note that in addition to increased work demand and wage cuts, heightened risks of gender-based violence faced by foreign domestic workers. And finally, many who became unemployed or hoped to return home to care for their own families have found themselves being stranded due to travel restrictions and border closures. I know migrant care workers in Europe and other parts of the world have also had similar experiences. The pandemic has not just affected these workers, it has also had serious impacts on sending countries as well. Migrants' job losses and or income reductions translate to falling remittance and household incomes. So, for example, in many countries in Asia Pacific, the impacts of remittance decline on household and national economies could be really devastating. The Asia Development Bank estimates that worldwide global remittance will drop by about 58 billion in 2020 as a result of the COVID-19. Of this, Asia Pacific region will see a decline of $31.4 billion. And in the case of Asia, about 54% will be lost from the Middle East, where a large number of and proportion of Asian migrant women work as foreign domestic workers. This means that many dependent families will have less money and in some cases may plunge into poverty. For countries such as Nepal, Pakistan, the Philippines, and Sri Lanka, where remittances from migrant workers overseas make up something like 23%, 9%, 9%, and 8%, respectively, of their total GDP, a drop in remittance of even a few percentage means a significant dent in their national economy. So, how resilient were we in responding to the pandemic? Here I have some good news, kind of, and a bad news. The good news is that the shortage of essential workers in key sectors such as agriculture and health and social care, the sectors where a large proportion of migrant workers are employed, have forced national governments and subnational governments in receiving countries to make changes and concessions to immigration, employment, and other policies in order to retain, recruit, and increase the supply of care workers, including migrant care workers. In Europe, for example, some governments have extended work visas, made exceptions to travel bans, and or granted temporary status to migrants if they work or will work in essential sectors. In my country, Canada, we had a very unenviable situation of having about 80% of the COVID-related deaths during the occurring in the long-term care homes. This is really terrible. This has resulted in severe care worker shortages in the long-term care sector. And in response to this, the federal government actually had to call in the army to help, to go into the long-term care homes and to help. It also forced some provincial governments to take pretty drastic measures. These include establishing paid training programs for long-term care workers with assured employment, plus a COVID emergency wage premium upon obtaining a certificate, and inviting both domestic and foreign students, unemployed people, immigrants, and refugees and asylum seekers to take the training. But the real bad news is that the essential care worker shortages continue despite these efforts, not just in receiving countries, but also in sending countries as well. And this is likely to continue unless we change the system and our thinking about care and care work. So, what is wrong with our current global care system? The problem is that our current care system is overly dependent on global care worker supply chain. Because care work is undervalued, not take the job. As a result, care work in most countries are downloaded to most marginalized workers in the labor market. So these are women, immigrants, and racialized and migrant women. In global context, this in turn further contributes to the formation and consolidation of global care worker supply chain. This concept is, of course, very similar to Arlie Hochschild's notion of global care chain, where she talks about how women in global north and global south are linked together through a chain of care. But here I want to spell this out as a labor supply chain, not just care chain, because I think it's important to see this as going beyond women to women individual linkages through care. We need to focus on it as a system of global labor supply and to pay attention to the tightness of the system, this supply chain, and the multiple institutions and actors that are all contributing to shaping and maintaining the types of care migration and the who, how, and where of the care migration process. Because this supply chain is also premised on the idea of economic efficiency in care services, what has happened over the years is that the chain has become increasingly tight to the point of becoming bare bone lean. This in turn leaves no room for flexibility, which is an important component of resilience. And indeed, what we saw was that our tightly bound, lean, global care worker supply chain simply crumpled under the COVID, intensifying the global care crisis. So in short, the existing global care worker supply chain is not resilient. It became completely paralyzed by COVID lockdowns and border closures, and the cascading impacts of such systemic paralysis on the social and economic well-being of people in both sending and receiving countries have been simply disastrous. So what can we do to build or rebuild a more resilient global care migration system? I think we need to do two things. First, we need to build local and national care capacity, or what economists may call this kind of built-in redundancies in both receiving and sending countries, so that countries are less dependent on the existing systems of global care worker pipeline. Building local and national care capacities will mean investing in human capital and social infrastructures for care, including more standardized and better trainings, and even certification for care workers if necessary. This will no doubt add to the costs of care and care work. But the trade-off will be revaluation of care work and better wages and better working conditions for care workers, more local and national citizens attracted to work in the sector, and expanded size and quality of care workforce. And again, less dependency on global care worker supply chain. Investing in local care capacities, however, does not mean a total rejection of global care worker migration. As populations in both sending and receiving countries age, and as the ideas about care change, global demand for care workers will continue to grow, and migrant care workers will still be needed. Instead, investing in human capital and social infrastructures will help raise the quality of care and increase and diversify the supply of care workers, and therefore making global care interlock more flexible and in responding to future shocks. Second, we also need a multilateral accord requiring both receiving and sending countries to adhere to basic labor standards for and treatment of domestic and foreign care workforces. This might include recognizing training requirements and certification, wage levels, and employment standards for both domestic and foreign care workers. A multilateral accord might look something like a modified version of Japan's Economic Partnership Agreements, or EPA, for care workers with Southeast Asian countries, but much more flexible in allowing recognitions of different skills levels, ranging from domestic work to more skilled healthcare work, and be organized at more regional or global level. Can we do this? I think it's possible. I think it's possible because I think if there is a time to make transformational change, this is the time. This pandemic has really opened people's eyes to the importance of care and care issue, and there is now a strong political support for increased government role in economic stimulus, social programs, and policy coordination. In short, we now have the political support for big government. In fact, the most recent polls in the US show that nearly 70% of Americans, including Republican voters, but not the Republican senators, are in support of President Biden's $1.9 trillion pandemic economic rescue package. This is an unprecedented support for government expenditure in the US. in some other countries, there also appears to be a growing support for increased government role in economic and social programs. As well, there are some positive signs of actual political initiatives to invest in care. One example is the recent passage of 1.9 trillion COVID relief bills by the Biden administration in the US, and the administration's commitment to appropriate $775 billion for childcare and education, and $450 billion for elder and disability care over the next 10 years. In Canada, too, the federal government has also renewed its commitment to creating a national early learning and childcare system, all in response to the COVID-19 pandemic. In fact, as a preview to the upcoming federal budget bill later this month, Canada's finance minister has suggested her intention to spend something like 3 to 4% of Canadian GDP, which is about $70 to $100 billion, between 2021 and 2024 on childcare and green recovery initiatives. And in both these countries, the government investment in social infrastructures and care are framed in terms of positive employment generation, promoting equality and inclusion, and economic growth. This is a very different kind of political framing from before. So given these new government initiatives to invest in care, the time, I think, might be ripe for transformational policy change. Well, admittedly, making real and substantive changes is a long-term process. But I think the COVID-19 pandemic has opened the doors to take action, and we must capitalize on this moment to make changes. I think the first step is to use this moment to rethink the value of care and care work, and to reconfigure the global care supply chain. So I will stop here and open for discussion. Thank you very much for listening to me. Thank you.